Thank you to everyone who has come out today. Thank you so much to my team to help get the word out. Since we're all here, we're just going to go ahead and start a few minutes early because I believe in starting early or on time, but not late. So welcome to our special roundtable today entitled At a Crossroads, the dual threat of Black maternal mortality and chronic disease. I am Dr. Akilah Weber, Assemblymember for the 79th Assembly District, and I am happy to co-host this important discussion right here at the brand new Southeastern Live Well Center located in my district. Yes. And thank you to the Partnership to Fight Chronic Disease for bringing this forth, this very important intersection of Black maternal mortality and chronic disease. Thank you so much to the staff here today at the Southeastern Live Well Center for providing this beautiful space for our seminar today. And last but not least, once again, thank you all so much for being with us here this afternoon, for taking time out of your day. I know it's in the middle of the day and many of you have other things that you would normally be doing, but you understand the importance and we're committed to coming to listen and participate. So thank you so very much. You know, I oftentimes serve a dual role in Sacramento because I am a board certified obstetrician gynecologist. And I also specialize in pediatric and adolescent gynecology. I am the founder and director of the Pedi-Gyn division at Rady Children's Hospital. And prior to going to Sacramento, I was also an assistant clinical professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences at UCSD. I went to Xavier for undergrad and received my medical degree from the University of Rochester. I then went on to Chicago and did my residency in OBGYN at Cook County, and then did a fellowship in Pedi-Gyn at Cincinnati Children's. I heard somebody over here say something about Cook County, so you know, for those of you who are aware, you understand the patient population that we serve at that particular institution. And so when we talk about things like chronic disease and the impact and the intersection between maternal morbidity and mortality, I saw quite a lot of that there. As a mother and an OBGYN, I'm also founder of the Select Committee of Social Determinants of Health in the California State Assembly, and the only Black physician in the entire state legislature. I am very honored to moderate today's panel with these very outstanding women who also work with Black maternal patients. You know, in our profession, we have realized a while ago that there are so many factors outside the walls of the hospital that impact our patients and their health. So are there food options where they live so they can have access to fresh foods to help manage their chronic disease such as diabetes or hypertension? Do they live near clean and safe parks or have sidewalks in their neighborhoods so that they can take those daily walks to help manage their cardiovascular health? Or do they live in environmentally hazard areas that have caused their lifelong asthma or other respiratory illnesses, or even some cancers? So when we ask these questions, we begin to understand the social determinants of health and the broader picture of what's happening within the communities in which people live that shape the health and their health outcomes. And when it comes to Black maternal mortality, the data shows that Black women are 3 times to die from pregnancy related to issues compared to white women. And this is regardless of your social economic status. So there is a card right here. I didn't plan this, but when I saw this, I said, this is it. Systemic racism is as real as any disease. Our industry is not immune. And actually, systemic racism is the root cause of a lot of the issues that we have, especially when we talk about maternal morbidity and mortality that you see across social economic lines. And when we look at these Black maternal deaths, more than half of these deaths are from preventable causes, with cardiovascular disease, which is a type of chronic disease, being the leading cause. So we are here this afternoon to really dig into this issue and hear, like I said, from some phenomenal women in this field. So to our esteemed panelists, I really want to thank each of you for taking the time to be with us. You're each extremely busy, but I am so glad that you were able to take the time out to join us today. I'm going to read their bios and then allow each panelist about 10 minutes to talk about their work and present their topics. And then we will end with a moderated question and answer, and you will have time to answer or to ask questions in the end. So our first panelist is Courtney Christian. Courtney is a Senior Director of Policy and Research at Pharma, focusing on state-based reforms impacting health insurance, prescription drug coverage and public health programs, and on health equity. Prior to joining Pharma, she worked at the Black Women's Health Imperative as the Director of Policy and Advocacy and on Capitol Hill for a number of years in a series of roles, including a legislative director. She's a Florida State football fan and alum. We'll give that a pass. We got some feelings. I got some feelings about Florida. An aspiring chef and a mom to an energetic preschooler. That's a great way to put. Is it a male, boy, or girl? I knew it because I got two. So energetic. That's a nice way to put boys. Okay. So this is Courtney Christian. Our next panelist is Dr. Cynthia Jamfi Bannerman. Dr. Jamfi Bannerman is a board-certified perinatologist who specializes in caring for women with high-risk pregnancies. She completed her fellowship in maternal fetal medicine at the Mount Sinai Hospital in New York and completed her OBGYN residency at the University of Miami, another Florida. Jesus. But you see, they're all here in California, so. She has a master's degree in biostatistics, which she got during her time at faculty in Columbia University. She joined UCSD in medicine in July of 2021, a few months after I left, as chair and professor of the Department of Obstetrics, Gynecology, and Reproductive Sciences. In her free time, she enjoys exploring San Diego's local hiking trails and the beaches with her family. And last but not least, I don't even know if I need to introduce this particular panelist because she's so very well known in the community. But we have Dr. Suzanne Afalo, who is originally from Kingston, Jamaica. She worked at Kaiser Permanente as a family physician for 23 years and retired in 2015. She received her medical degree from George Washington University School of Medicine in Washington and completed her family medicine residency at Kaiser Permanente Medical Center in Los Angeles. Even though she retired in 2015, we know that she has not stopped working to improve the health of the residents that live right here in this community. She was medical director for the Alliance Health Clinic for 5 years from 2017 to 2022 and is currently the medical director for IWC Primary Care since 2020. She serves on various boards, including the County of San Diego's Health Services Advisory Board, the UCSD Chancellor's Community Advisory Board, SDSU Communities Fighting COVID Advisory Board, and the San Diego County Childhood Obesity Initiative Healthcare Domain, which she is co-chair of, and this is just to name a few. Over the past 25 years, Dr. Afalo has spent her free time, and we've all seen her, volunteering in the community, lecturing on high blood pressure, diabetes, heart disease, obesity, breast cancer, and other health-related issues. So these are our three panelists. If we can please give them a round of applause. And we will just go in order.
Thank you so much, Dr. Weber, for convening this really important conversation today. And I'll just say, Florida State is undefeated, 7-0 for the first time since 2015. Go Noles. But that's a great segue into something else that happened in my life in 2015. I turned 39 at the beginning of the year. And I had said, you know, if I was 39 and childless, I'm going to be the most fabulous aunt to all the rest of my good girlfriend's kids. And then in March, a little something happened, and I went to the doctor and said, "I'm sorry, what?" And there was a little person, the energetic second grader. Sorry, I think that bio was a little dated. The energetic second grader. Who was making his way into the world. And as Dr. Weber mentioned, I was working at Black Women's Health Imperative, which is the only national nonprofit really focused on Black women's health from beginning to end, and really just ensconced in the reproductive justice work there. So I knew all the statistics about maternal mortality and being 39 and being labeled advanced gestational age. I was like, I'm advanced, okay. But I was intentional about my pregnancy. I sought out a Black OBGYN. She was very meticulous about my care. And right at the 8-month mark, I went in and she said, "I don't like any of your numbers. You're having this baby a month early." And in I went to Sibley Hospital on a magnesium drip. I'm not allowed to get out of my bed. Gave birth to a beautiful baby boy, but was scared every step of the way because I knew the stats. And I don't know if you all know, but in 2010, the NIH issued a study and found that Black women are nearly 8 years biologically older than women, meaning that if a white woman and a Black woman are the same age, the cumulative effects of stress effectively age Black women 8 years beyond her actual chronological age. And I'm sure these women could probably tell you a lot more about the epigenetics of stress than I could. But, you know, what causes stress? Worry about our jobs, our kids. Are we advancing to the next level at our job? Are we dealing with microaggressions? Are we under scrutiny all the time? All the things that Black women face. Family responsibilities. We're usually the main breadwinners of our families, the person everyone goes to advice. We're thinking about where we're living, how we're eating. Are we getting healthy food? Are the kids dressed? Can I pay my bills this month? And so then it's no wonder by the age of 30, which is prime childbearing age, that Black women's bodies are overloaded by stress hormones, which in turn impedes the development of healthy babies and healthy pregnancies. And so, as Dr. Weber mentioned, the stress overload leads to a really startling statistic that nearly 50% of Black women deliver their babies too early. Preterm birth is high among Black women regardless of income or level of education. In fact, educated professional Black women have higher rates of low birth weight babies than white women without a high school diploma. So, you know, regardless of income level or education level, there is a really stark problem here. Native American women are twice as likely to die at a time when 48% of tribal households do not have access to clean water. And then women who live in rural America, where there are many maternal care deserts, are about 60% more likely to die. So we have a really extreme national crisis on our hands. And these outcomes are largely due to systemic inequities that we face every day, that women face every day in accessing healthcare, that are really a matter of life and death. So we know the statistics around health disparities are bad, but COVID-19 just really removed the veil and showed everybody these stark disparities were here, and they are worsened because people didn't get to have timely access to care, timely access to screenings. And so what was already a problem just worsened and deepened. So now is really the time for all of us to come together. This conversation is a great start, and I know you all will go back out and carry this into your communities, but think about solutions. What can be done at the state level, at the federal level, at the county level to mitigate some of these outcomes that we're seeing? So at Pharma, we are really focusing on disparities from a lens of social determinants of health. Where we live, where we work, where we play, how those drive health outcomes, how it drives people even accessing health care in the first place. And so one of the tools that we have developed that we're super proud of is just debuting in the last couple of weeks is this simulation that you see here on the screen behind us, where we're walking our member companies and other organizations through what it means to navigate your social determinants of health and to navigate your access to care. And so you'll see here our credo here that we believe that diversity, equity, and inclusion are essential to the discovery of new medicines, and that people of all ethnic and racial backgrounds should have equitable access to treatment. And so this exercise is really to illuminate the inequities in the healthcare system, but also to illuminate the patient experience of trying to get to healthcare and access it in the first place. And so when you go to the QR code on the back of that card that has our statement that systemic racism is as real as any disease, and our industry is not immune, that's us facing up to what do we need to do to sit at the table with advocates just like all of you to figure out our spot, our place to try to fix some of these inequities as well. And so you'll see here as we go through this simulation is that we've got 5 different patients here that you can experience a journey through their eyes, and you can pick one or you can randomize it. I'm gonna pick Tia because I told the designers, I think you guys were trying to make one that looked like me. And so you see here that Tia she's 50, she's been diagnosed with severe depression, she lives with her husband Jerome and her 2 children, Elijah and Aaliyah. And then you can see here her social determinants of health. She has a safe automobile, she lives in a suburban neighborhood. Her neighborhood has high walkability, as Dr. Weber was just alluding to, sidewalks and green spaces. She eats organic and vegan products only, and she makes $250,000 a year, which with inflation, I don't know how much right now in these times. She has access to multiple computers and devices. She has employer-sponsored insurance. So based on her social determinants of health, this Tia avatar is starting out with a token balance of 15 tokens. And you can see in this simulation, as with Tia and all the other avatars, these tokens represent the social advantages or disadvantages to accessing a prescribed medicine and accessing the healthcare system. So more tokens are indicative of a higher likelihood that a patient can access the healthcare system and access needed medicines. And so as we go through here, oh, that was a big ding. You can see again that Tia lives in a city with a great environment, in a neighborhood with a great environment. They've got green energy strategies to address air and water pollution in her area, which help her live an active and healthy life. So she gained a few tokens there. She gained 2 tokens. But then throughout this exercise are some did you know pop-ups so that people are taking something else away from this. So I mentioned earlier 48% of tribal households and Native communities lack access to reliable and clean water. If we move along and take her to a screening at her doctor, she's coming to see one of these doctors. Here, she's able to participate in a clinical trial for a nominal cost to her, and clinical trial is super important to health equity and to health access and to maternal mortality. And so she's had access to the internet, and she can schedule her follow-up appointments. And then here, I think as in life, you get to the fork in the road, as Robert Frost said. Are we going left or are we going right? And on this path, you can decide which path that she takes. So we're just gonna go and see what happens to the right, because I've forgotten. Oops, she doesn't have access to a provider and screening. So she's unable to receive a follow-up screening due to lacking time off work, which is a real thing, especially for expectant mothers. She lost some tokens. And then here again, some did you know statistics. Did you all know that Asian and Pacific Islander women are 2.5 times more likely to die from stomach cancer compared to white women? That's probably because of later diagnosis in advanced stage disease. But in the end, Tia is able to receive her right prescription. So her physician, one of these 2 ladies here, prescribed an innovative treatment to help her better manage her conditions. But you can see here that fork in the road is an important one, whether you go left or right. It depends on your resources. It depends on where you live. It depends on what you have access to. It depends on your economic situation. It depends on so many other things. by the time you get to a healthcare provider or to a pharmacy. And so today, I'm just really honored to talk to these ladies, even though you're a hurricane. And there's a super big rivalry for those who don't know, Florida State and Miami, University of Miami. But so glad to be here to take part in this conversation about a really critical topic that affects all of us.
That was wonderful. I'm going to switch over here because I have a little presentation for y'all. 1 second. All right, perfect. Can you all hear me well? Let's see. Okay, is that better? Yes. All right. Who knew I would come here and sit next to a gator? Oh, you're a Seminole, even worse. Oh, I'm just joking. It's a rivalry for decades and decades. The one thing we have in common is that we both had kids at 39. My younger son actually was born when I was 39, and he's 11. He's almost 12. So it's yes, I've had some high-risk pregnancies myself, and I'm just really honored. Thank you for inviting me to speak to this group, and I'm really honored to be here with you all. So I guess as a professor, I'm very much used to giving lectures. I also am a very visual learner, and so for me, seeing things helps, and so we'll just go through a few slides, and then I know we'll have time for questions at the end. So you all are, I'm sure, are familiar with the Lost Mothers series. It came out in 2017, and you can Google it. It's still available. And if you click on each of the faces, you'll actually see their story. And it was done by ProPublica. And it really brought light for the first time to the issue of maternal mortality. Before that time, people were essentially in medicine high-fiving themselves because maternal mortality had gone down quite a bit, and part of that was due to things like antibiotics and sterile procedures. So when you look at maternal mortality compared to 1900, yes, it had improved, but actually it was ticking back up since that time, and people hadn't noticed. And so this series was really important. And they focused on a few people, and I won't go into too much detail. This is a couple who lived in New Jersey. The man is an orthopedic surgeon, the woman is a nurse, and she delivered at a community hospital. And her blood pressure was so high that at one point, her nurses turned it off because it was just beeping too much. Within 24 hours, she died from preeclampsia. So that was a pretty sad, very sad story. This one was more local to us in LA, a woman who was having a C-section and had some complications after the C-section that weren't recognized in a timely fashion. And then this little beautiful baby, her mom died postpartum, and her mom actually worked for the CDC. She was a PhD working in the CDC on the same floor where my sister works for the CDC in Atlanta. So my sister actually knew this particular patient. She was coming in with a variety of complaints to a variety of providers in the first week postpartum, and it wasn't recognized again that she had preeclampsia, and she died. And so these stories are way too common, and it's not a coincidence that there are more people of color on this slide than not. There's also been a spotlight on the racial disparities, thanks to Serena Williams, who helped really bring this to the forefront because people were not listening to her. But there are quite a few issues in terms of both maternal mortality as a concept overall and the fact that we have disparities related to these mortalities. And then to put it into context for you, and I know that you all know this as a savvy audience, but when you compare us to the rest of similar countries, we're really doing very poorly. We have a similar maternal mortality rate to the Middle East and not to any of the other countries that we would compare ourselves to. Again, these are some of the disparities that you can see, and these are relatively recent numbers up to 2021. What's probably the most concerning about this slide is that for all people, the numbers are going up, not down. So despite us talking about this quite a bit, we really haven't seen an improvement for anybody in maternal mortality, and the disparities continue. And now I know we're joking about age, but this is actually the age-related risk. And you can see that much of this mortality is in women who are 40 and older, which starts to get to that there are conditions that are going to be more common in older women, and we really need to be paying attention to these and think about these as we're thinking about pregnancy in this age group. So essentially there's two major problems, and I think the group has outlined them already, but not only are mothers dying more frequently, but Black mothers are 3 times the risk of death to other populations. So all of this came about from the series really in 2017, but I just want you to show, so I'm actually president-elect for the Society of Maternal Fetal Medicine, and in 2016 we put out this paper as a call to action to say that there's a problem and that we need to start to reduce the racial and ethnic disparities in maternal morbidity and mortality. So we've been working on those for quite some time, but we obviously have a very, very long way to go. One of the things that this paper did was it identified some of the research gaps, so for those of us who are interested in research, we can really start to look to see what some of these solutions might be. So it's estimated that 700 to 900 women in the United States die from these pregnancy-related causes each year, and as Dr. Weber mentioned, over half are preventable. The problem is when you look at the most recent numbers for 2022, it was about 1,200 women that died. About 70,000 women in the U.S. experience severe maternal morbidity, so get sick close to the point of dying, but don't actually die. And as I mentioned, we're ranked number 46 in the world for maternal mortality. So as people started to look at this, part of what happened with the uptick was that people weren't really counting maternal deaths in the right way. So they weren't counting postpartum deaths. They certainly weren't counting deaths in the first year of life. Those were ignored. And so not all states were really counting those numbers appropriately. And so things really have changed in the way that people are starting to count numbers. And so we're starting to see that more deaths really are, in fact, related to pregnancy. In 2003, the death certificate had a checkbox that identified pregnancy. And that's really one of the first times that we actually were able to start to see that these are pregnancy-related deaths. And so death rates were recalculated based off of that. So what about the morbidity? What about the part where you're getting sick? So the CDC has defined all of these causes of severe maternal morbidity, and these are more common in people who have hypertension, diabetes, all of these issues. You'll see many of these happen more commonly. Things that happen in our communities, sickle cell disease with crisis, blood transfusion, hysterectomy, all, again, more common in our communities. So the CDC has some definitions, and you're not seeing these. These are a couple of studies that we did to try to understand what the problem was. So we looked at postpartum hemorrhage and identified some racial barriers there, and we also looked at readmission rates and found that there were racial differences in the literature. So I think what we want to know is, what are we doing about this, right? So I'm a researcher. We do, and a doc, I like to deliver babies. But we do a lot of research, and I think it's really important. You know, look at the death. What was the cause? Was it preventable? Was there an underlying cause? What can we do to prevent this in the future? What were the other factors that were involved? And what are the impact of the actions of many of these things? So we here in California are very lucky in that we have had maternal mortality review committees for quite some time. This is not as common in the rest of the country. And even today, only 49 out of the 50 states, there's still places where they don't look at maternal mortality numbers. But 49 of 50 have some form of review. 36 states review deaths up to 1 year postpartum. Happy to say that California is one of those. 14 states are required to determine if the cause of death was preventable. Again, that's what we do here. And 8 states investigate or consider racial disparities and equities. And I know that we have these reviews ongoing. So descriptive studies are going to be really helpful to let us understand the problem so that we can start to fix it. So if you were asked what were the top 3 causes of maternal mortality, and you said hemorrhage or bleeding, preeclampsia, or having a blood clot, you would be correct if you were in 1987. So really important to keep the research going because things are changing. And so we've actually gotten a little bit better at looking at hemorrhage and looking at preeclampsia. But now the most common causes of death are cardiovascular conditions, cardiomyopathy or heart disease, and then sepsis or infection. And so we really do need to look at these, because this is what we need to work on now. Why are women getting infected? Do people have underlying heart disease? Are they not identifying this heart disease before they're pregnant? And then pregnancy is like a stress test, and so it just makes things worse. So these are the top causes of pregnancy-related death. Again, like I mentioned, cardiovascular disease, cardiomyopathy, and sepsis. But then I wanted to see, well, what about us here in California? And so our biggest cause of maternal mortality is cardiovascular disease also. And you can see the numbers there. So we here locally need to try to focus on the same things that are causing death nationwide. Importantly, one of the deaths happening, so about 30%, this is nationwide now, 38% happen while pregnant. The rest of them are happening postpartum. And so we really need to focus on the postpartum period. It's very important. And then again, in California, you can see that while the largest time for a mother to die would be at the date of delivery, more deaths are happening also postpartum rather than in the beginning. So what about what we're doing at UCSD to try to improve these outcomes? So I've been at UCSD now for about 2.5 years, and we're very actively working on this problem. One of the first things we did was we had our department retreat and we changed our mission and vision statement. Obviously, I'm not going to read them all, but the very first one on the list is to involve our community in our care and really have equity focus and evidence-based care for our community. And we've been actively working on that, and I'll share just a few strategies. We've communicated maternal equity as a priority. We are collecting and disaggregating our own data so that we know what we're doing by race and ethnicity. We're a member of CMQCC, which just collects data on pregnancy, so we're trying to get more information. And we're educating our clinicians, and so all of our clinicians have had specific training on the effect of racism. We talk about racism a lot in my department, so no one in my department is afraid of the term racism. We use it all the time. We formed a culture and justice quorum, and so that quorum has several goals, and one of them is to engage the community. So I'm not going to read all of this out to you, but our quorum is led by Dr. Audra Meadows, who is a wonderful both OBGYN and community activist who has come here also fairly recently, so she's been here for a couple years. I'm not going to go through all of this, but there's a multi-pronged way that we're trying to work in our culture and justice quorum. One of them is through education, through clinical work, through engaging the community, and also administration. But our newest project, and something that I would love all of your feedback on, is our 4th trimester project. And so as we're seeing that deaths are moving postpartum, and as we're seeing that women need more help postpartum than we can give them, we're hoping to start this project, and eventually it'll be brick and mortar where people can actually go and see our providers, but it's a multi-pronged effect, and so we'll have people who will take care of both the mom, the baby, lactation, postpartum doulas, pelvic floor, all of the things that a postpartum person would need. Maternal mental health, it's another priority of ours. And so we're just in the starting phases. I have some faculty working with me to get this program going. And it's really dedicated to providing comprehensive postpartum care for our patients. So we'll try to co-locate a whole group of things. And I mentioned some, but there's so many pieces that we're going to try to put together, including newborn care, pelvic floor. I mentioned the doula and mental health, social work, all of these things that it's a struggle for women to get to in the postpartum period, and so hopefully we'll have all of this together at one point. So just to summarize, we still have a whole lot of work to do, but we understand a lot more now than we did before. We have our culture and justice quorum, so we're really trying to make changes at UCSD. We have renewed focus on our postpartum care, and we're really working on this postpartum 4th trimester project. So thank you again for allowing me to speak to you all, and I'm excited to see what we get to at the Q&A period.
Okay, good afternoon, everyone. So there's 2 things different from me with these two young ladies here is that I have nothing to do with Florida or any of their universities or anything. So I'm not a Gator or whatever the other one is. And the second thing is, I'm not sure if I got the memo or confusion, but my PowerPoint is right here in my hand and not on your screen, so I'm just going to go with it. Anyway, humor me. And the information you'll still get, okay? Nonetheless, I won't be up there and you won't have anything to look. So you can look at each other or look at the blank screen, or you can look at me. So basically, because I'm a family physician, my focus is a little different. And it has a lot to do with keeping everyone, but especially women, Black women, healthy. So that when they do decide to get pregnant, that they'll be at their best health and be able to have a better outcome. So I'm going to just dial it back just a minute to say that when I speak about women's health disparities, I want to go back to where we're talking about reproductive health, period, before we even get to the point where they're pregnant. And so I will be reading a little bit, and Black women are especially affected as they already face greater obstacles than non-Hispanic white women in obtaining sexual and reproductive health services, period, before they even get pregnant. As a result, these disparities, Black women have higher rates of sexually transmitted diseases or infections, reproductive cancers, and unintended pregnancies than other women. So we're already starting off with behind the 8 ball before we even get pregnant. And so as Dr. Weber mentioned, Black women are at least 3 to 4 times more likely to experience pregnancy-related death than white women. Unintended pregnancies are the highest among poor and among young and Black women. So we're talking about even having pregnancies that are unintended at the time. And which that means is sometimes they're not going to get the care that they need during that process. Black women have higher rates of unintended pregnancies than other races, and they lack the access for quality contraception care and counseling. So, you know, they don't necessarily want to be pregnant. They may not have an option at that point. And in some states, we already know that the option's not there to terminate if they don't want to. And so you're carrying a fetus that you not only necessarily don't want, but also you're not getting the care that you should get during the process. Black women are 6 times more likely than non-Hispanic whites to be diagnosed with chlamydia, which of course can cause problems and scarring of the tubes and things like that, which will later, when you decide you want to get pregnant, can cause problems. 12 times more likely to be diagnosed with gonorrhea, and 5.5 times more likely to be diagnosed with primary and secondary syphilis. So we're talking about infections before they even get pregnant, and they can have some effects to when they actually do get pregnant. Black women are twice as likely as white women to die from cervical cancer. So, and this happens in early ages, even in their 30s, so some of them may not even get a chance to get pregnant, okay? So Black women and reproductive health, there are, of course, if you've heard, the theme is social determinants of health and the barriers. So compared to white women, Black women are more likely to be uninsured, face greater financial barriers to care when they do need it, and less likely to have access to prenatal care. So that is so key when you're trying to have a healthy pregnancy and you don't have access to get anywhere. You don't have the prenatal vitamins you need, the folic acid, things like that, to make sure your pregnancy is healthy. And then you may get there in your 2nd or early 3rd trimester when it's kind of already too late to, get a hold of the chronic diseases that you may have. Black women experience higher rates of many preventable diseases and chronic health conditions, including diabetes, hypertension, and cardiovascular disease, which has been mentioned. And that's really the bread and butter of primary care. That's what I deal with. And so I will speak a little bit about that and answer questions later about that too. Black women when they choose to become pregnant, these health conditions influence both maternal and infant health outcomes. So it is important in primary care that we take care of their chronic diseases so that when they do decide to become pregnant, they are truly healthy or at the best that they can be. We don't need diabetes that's out of control, hypertension that's out of control. That's going to put their risk for eclampsia even higher. We've got to get them under control, and the best thing to do as a primary care provider is to educate them on the fact that before you do get pregnant, let's plan this, and let's get all your chronic diseases. If you do have chronic diseases, make sure that they're identified, that they're controlled, and then that way you can now start to plan your pregnancy. Black women should receive health care that is respectful, culturally competent, safe, and at the highest quality. And I'm sure there's many black women in this room that those adjectives do not describe some of the care that we get in the room with our providers. And so for that, we tend not to go back. But who does that hurt? It doesn't hurt them, it hurts you. Because if you don't go back and seek care, then the conditions that you have are just going to get out of control. So I always tell people, jokingly but very seriously, that if you're not happy with the provider you have, fire them and get another one. You do not have to stick with someone that you don't like, that doesn't seem to care for you, that is not going to be your advocate. You need someone that's going to be in a camp with you, that's going to take care of you, give you the best information that you need, educate you on the decisions that you need to make for your health conditions. They're not their health conditions. And I tell my patients all the time, I don't have diabetes, but I'm going to educate you on how you should take care of your diabetes. Okay, so if we can form a relationship with our patients, then we can help them make good decisions and stay healthy. Unfortunately, research shows that black women receive a lower quality of care than white women. And I already tell people that, beware. When you go in and you look like me, they're not going to offer you the same type of, resources that are necessary. They're going to poo-poo the things. They're going to not pay attention to the symptoms that you have. They're going to minimize that. And so you have to be aware, and I teach them to be their advocates, their own advocates. Challenge the provider. That's what they're there for. They're to take care of you, okay? We pay their salary. And so with that, you need to make sure that you go in with your questions, come prepared to make sure that you know and understand your health conditions, that you don't go out as uninformed as when you went into the office. Black women are subject to discrimination in the healthcare field. 22% reported, according to the women that go in to their doctors or the clinic. Policies should be created to eradicate cultural biases and discrimination in medical practices and medical education, and should strive to increase provider diversity in primary and maternal care. So what that means is we need to start from a very young age educating people that look like us to go into the medical profession and to therefore hopefully understand what we're going through, and we can feel comfortable when we go in the office that someone has a sense of the plight that we've already gone through, okay, as black people and as black women. I also say that we should, as any black woman should be able to go to a black OBGYN. There's not very many. You can probably count them on one hand in San Diego, but be able to go at least once or twice throughout their pregnancy to this provider, even if it is out of network. They need to see someone that looks like them. They need to look at their plan and make sure that the person that's taking care of them is doing a great job, and that they can answer the questions that they may not feel comfortable asking the provider that's taking care of them within their network. So what pregnancy risks do black women face? For black women, childbirth has been a scary experience. With the statistics of black maternal health care improving at an embarrassingly slow rate, black women must be vigilant before, during, and after childbirth to maintain their own health and well-being, as well as their children's health. And black women are at a disproportionate higher rate for certain medical conditions while pregnant. So black women also have a higher chance of dying from most preventable birth-related complications, which has been mentioned, and delivering preterm babies. So I do believe you said you had to go 1 month early because they did not like your numbers. And so had they waited, or had you not had a provider that was paying attention, you would have gone longer and had lots of complications. So thank goodness for the provider that you had. Black woman, thank you. As I said, so black woman OBGYN, thank you for that. We have 2 right here in the room and maybe more. So the quality of prenatal care for black women can look very different from the prenatal care offered to other women. There's historical myths of black women being able to tolerate more pain, as well as not having access to quality health care before and during pregnancy, and contribute to the long list of pregnancy risks that affect black women more than other races. So when a woman is complaining about pelvic pain or something like that, they pretty much ignore them and don't want to treat them, but they might need to look and see what's going on. They could be bleeding internally, there could be anything going on, and they ignore it. Sometimes they send them home and they end up dying. Or they come back in complaining of the same symptoms, and it's like, oh, you're gonna be fine, and send them back home, and then they go home and die. So we need to change the mindset of the providers, because half of them, I'm just going to be honest, I'm speaking on behalf of my colleagues, and I'll apologize beforehand. Some of them just don't care. I'm sorry, they just don't care. And so if you do realize that or feel that way, please don't stick with them, because your health and your life is in their hands. So I need you to find someone who cares about you, who you feel is concerned about your well-being, and make sure you stick with them. There's some risk factors, like we tend to have high blood pressure and fibroids, which can certainly contribute to some issues. When pregnancy risks what pregnancy risks do Black women face? Well, there's a display, obviously Black women display signs of preeclampsia earlier in pregnancy than white women. This condition, which involves high blood pressure during pregnancy, can lead to severe complications, including death, if not properly treated. And that's where we tend to lose a lot of our women, or have in the past. And then you mentioned something that has a term for it. So Black women experience physical weathering, meaning that their bodies age faster than white women due to exposure to chronic stress linked to socioeconomic disadvantage and discrimination over the life course, thus making pregnancy riskier than earlier age. So that term that you're referring to is called weathering, where our body is weathering more than the average woman. And Black serving hospitals, so the ones that hospitals, and probably in the South and other places where they're serving Black women, have higher rates of maternal complications than other hospitals. They often perform worse on 12 of 15 birth outcomes, including elective deliveries, non-elective C-sections, and maternal mortality. So there's providers, there's hospitals out there that tend to serve Black women. They do even more poorly than everyone else. So what can Black women do to reduce pregnancy risk? First of all, get to know your new body better. Your body will be changing during pregnancy. Understand that. Learn to speak up for yourself in all situations, especially with your medical provider. Do not go home and not ask those questions, those important questions. Find a provider or a practitioner you trust. Each provider has its own communication style. If they're speaking a different language, which has nothing to do with empathy and compassion, you need to go find someone else. Find an advocate for your delivery. You need someone in the delivery room, like a doula or a midwife, to help you manage your decisions. Okay, sometimes things get really rough and you can't really think straight, and you want to have someone in there that is going to help you stick with your plan unless there's some emergency that comes about. Preconception care is just as important when you are planning to become pregnant. Check on your overall health. Making any dietary, physical, and mental changes before pregnancy will get better equipped for your pregnancy. So make sure you check in with your mental health, your physical health, and all the well-being before you get pregnant. So that's a preconception care. And then follow the rules. You know, we are not very good patients sometimes. So follow the rules. Avoid the alcohol, the tobacco, the drugs. You know, start eating a little healthier. Whatever you did before when you're getting pregnant, make sure you eat healthier. Stay active. You don't have to gain more than the 25 pounds that we recommend. You know, so 40 pounds is not the baby and the placenta. Okay, there's no excuse. You're eating for 2, but we just need you to gain no more than about 25 pounds, okay? So take your vitamins and the medications as prescribed. So if you have high blood pressure and things, they will adjust medications so it's safe during your pregnancy. Labetalol is one of them. There's others. So make sure you take the medications. Get the support from day one. So possibly a family member or a friend who has been a mother, who's gone through some of this, who can encourage and support you mentally, physically, and emotionally and spiritually throughout the pregnancy and the postpartum. And prepare for postpartum plan, which is 4, right? is trimester 4. So that is just as important. And as the doctor said, that's where we're starting to see a lot of our loss too. So the days and weeks after delivery are tough, and there are many complications and other concerns as you heal from pregnancy. Make a plan for your postpartum care. So my last little flyer, which I thought was really cute, says Black women matter. So make sure that you take care of yourself and take care of anyone that you know that is, you know, thinking about getting pregnant. Make sure that you remind them that they need to take care of their general health first, before they think about getting pregnant, because you're not only having to take care of you, but also the fetus that they're going to be carrying. So with that, I will say thank you for having me.
Thank you so much for all of those presentations and all of the information that you all have given us. We will have someone who is in the audience who is able to take questions, so you can just raise your hand and she will come to you if you have any questions. I am going to start though, and Courtney, I want to ask you a question. You know, recently we have had the Supreme Court decision impacting affirmative action. And even though that decision was specific to higher education, we are now seeing it spread into other areas where you start talking about programs that focus specifically on certain races or dealing with racial inequality or DEI kind of programs. When you are trying to fix an issue that is very specific to one racial group, how are you going to be able to navigate those waters in the future where it may be something that is challenged because it is putting time, energy, and effort and resources into one particular group?
Yeah, thank you for that. I'm supposed to be talking to myself. Thank you for that question. We are really navigating really tricky waters politically, I think, as a country, in dealing with a court that I think acts in a different way than we're used to seeing. And this is me without my pharma hat on. But I will say that we have looked with some alarm at that ruling because, yes, while it's narrowly prescribed right now, it sets a precedent to affect every other corner of academia, in the workplace, in our lives. And so what I really, and what we're really trying to think about is how this affects medical professions. People going into STEM education, once you start kind of removing some of those things that helped our parents and folks after us get into some of these places that were not meant for us to be there. They were not built for us to be there, but we work hard through merit and grit and determination to get there. How do we make sure that those gains are not lost? And so those are, I don't think there's like a one-size-fits-all solution to that. I think it's a case-by-case sort of determination of like, what do we do as a community to lean in and say, no, it's important that this PA program at Howard University lasts. It's important that there are a certain amount of students of color at this university who are being trained to be doctors and being trained in various professions. There was something that both of you all hit on in your presentations, and that was around implicit bias, which is something that we're looking at pharma in terms of like how, we're all human beings. What experiences do you bring to your practice? And how does that affect you referring a patient of color to a clinical trial, to access a certain medicine? If you are already in your mind thinking, that person might not need it, you're bringing your bias to that. How do you combat that? And this is one way to combat it, to make sure that there are people being trained and coming up through training that have those lived experiences of communities of color, but also are able to talk to and it's always the onus is on us, but to share with their colleagues and to make sure that the right training apparatuses are in place so that bias kind of is mitigated at some point.
Yeah. Thank you so much for that. And I think when you start to talk about what would be the impact on providers within the healthcare system, I think California is a good example of what happens when you don't have affirmative action or you're not able to look at those policies. But I also think that UCSD would be, I think, a good example of that. When I started there, it looked very different than what it does now. It was not an easy place to talk about racial inequality at all. And I was the only one there, and I don't even remember when they had a black resident prior to that. But just a change in the focus and a change in the leadership can do a lot in a very, very short amount of time. But seeing that, we do, here in California, we do have those constraints of like Prop 209. We do have a decreased number of blacks in our CSUs, in our UCs, undergrad, grad, and unfortunately within our residency programs and fellowships as well. What is it that we can do to increase the pool of diverse providers in California? Anyone?
I can speak to that. I think we're very actively doing that at UCSD, particularly in my department. We are just about to start our residency interviews. And there are things that we cannot do with Proposition 209, but there are things we can do. We can look at people's distance traveled, and we can look at other parameters. We actually had a program that we had just started to try to recruit more medical students of color to come and do rotations with us, and we had to change the language a little bit to be more inclusive, but it's still targeted towards medical students of color so that they can come and experience a rotation at UCSD, because we're actively trying to recruit people who look like us to serve the community that we serve. And so it has to be intentional. You have to think about it. And frankly, the one thing I do like about the UCSD system, coming from the East, where I did, we joke about it, but I did everything at University of Miami, and then I worked at Columbia University for 16 years before coming. At Columbia University, there was never a mention of diversity or the importance of diversity, whereas everybody who applies to a job at UCSD has to have a full statement on what they've done for diversity. And it's a very different feel, it's a different culture, and so we're trying to, continue in those goals.
And I think all of those things are new since George Floyd.
Can I add to that? California is an interesting state. And so we have very few people of color here. Not very many African Americans are going into medicine. If they are, they go into more of the specialties rather than family medicine, primary care, which makes it very difficult. But it's very hard to stay here. So even if you train here, they tend to go back to the South or to the East, because it's unaffordable to live here. They come out of medical school with $300,000 worth of debt, and then it costs a fortune to live here. They'd rather just go back somewhere else. So when I was chief of family medicine at Kaiser, I had the opportunity for 6 years to hire people. I got one black person to interview, and he stayed a year and went back to Vegas. And I kept asking Pasadena to send me more African American recruits, and they had none in the pool. So they're not looking to come to Southern California because it's too expensive. And if they do come, they don't stay long. We've lost 3 black female providers in Kaiser in the last year. 3 black females. One moved to Vegas. One, I don't know if one was married and had to move, but that's devastating because that's probably 3 out of 6, right? So we've lost 50% of our black female pool in family medicine. So that's disheartening, and we can continue to train people coming up, which is great. But we need numbers here, and it's hard because the culture is not very welcoming, and it's unaffordable. So we're going to be struggling for a very long time. But you can get lots of black folks in the South and the East and DC and everywhere where you feel like one of everybody, and out here you're like a fish out of water.
Yeah. I mean, cost of living is definitely a challenge here in California. But it's a challenge for everyone who works here. And so I think that culture and that climate for black physicians when they work here is also a huge factor in why it's challenging, and some people do leave.
Yeah, I just wanted to say one thing before I forget, and it's neither here nor there, but for everybody to know that we have 3 black OBGYNs just at UC San Diego. 2 of us do high-risk care, 1 is a general OBGYN, and we have twice as many Latinx docs also at UC San Diego. So great place to get your care if you're looking for women's health.
And you can pat yourself on the back for that because they were all hired under you over the last 2 years.
Can I double click on this just a little bit though?
Of
Just because I know there are some leave behinds in your folders, but one of the leave behinds in there from PFCD is a national fact sheet on health equity, and in there on the back side of it, there's a stat around primary care shortages, which I think is a central driver also of this kind of conversation, which is a policy solution that DC in its current, I don't know what vote on the speaker they are on right now, but in its current state is something that needs to be addressed, the graduate medical education residency slots. We know that a lot of times doctors that get those slots, they tend to stay in the States, but then, of course, if we're talking about all the other determinants of health, where you work, how much it costs to live, you're going to go back somewhere else. But the main thread I wanted to pull through here is the primary care shortage. So if you don't have doctors going into medical schools that look like us, graduating, and then we already have a primary care shortage that's just really looming, that puts us even more at risk, I think.
Yeah, I think you just opened up a whole nother an issue there at the federal level in dealing with the shortage of primary care providers. And maybe Dr. Afalo can talk about that. I have some ideas on why that is, but.
As a primary care provider, the lifestyle is unsustainable. We can see the patients, but they keep adding on so much work on us. Our in-basket, you don't know what that is, but that's, our in-basket is crazy. I mean, it takes you like 8 hours to just do that on one day. So it's the messages, the abnormal labs, the prescriptions, the refills, everything, messages from other people wanting your MRI results that I didn't order, you know, but your orthopedic doctor ordered, but everything lands back on the doorstep of the primary care provider, which is unfair. So not only do they bombard us with 20-something patients a day, which is not realistic and not safe if you're trying to manage more than one problem, but the stuff that you have to do outside of seeing the patients, what's not sustainable. The more we hire, the more they leave out the back door, because we can't survive. And nowadays, the younger ones want a 9 to 5. They want banker's hours. They don't want, when I was trying to hire them, they don't want any urgent care, they don't want any call, they don't want anything. They just want to come in, see a patient, and leave. And that's not what medicine's all about. So we're kind of losing the dinosaur mentality, my mentality of, you stay to do the work and you see the patient for as many problems as you can. But now they're saying, you got 15 minutes, I can only see you for one problem. I'm like, what? So the mindset of the providers that are coming into primary care is a survival. They want work-life balance. And that's not really great when you're trying to be a family medicine primary care provider, because they have more than one problem. You can't just address their diabetes today and then send them back and come back in a month for the appointment for their blood pressure, because by then they would have had a stroke or a heart attack. So we need to be realistic. They need to get more primary care providers. They are not sticking with it. More people are going to subspecialties. I'd rather be a dermatologist. I can see 20 patients, see that one mole that you have. I don't have to think about everything else that's going on. I mean, we have to be the caregivers for everything. Your orthopedic, I got to inject your knees and your shoulders. I got to, take care of all these other issues, your rashes, your pelvic, your exam. It's like a lot. And then we have an in-basket. So if somebody could do our in-basket, we can be sustainable.
Sounds like some issues that should be addressed at a federal level or even a state level. But I also know there is a discrepancy in pay.
Yes.
And so while, all healthcare providers are definitely important, they definitely have certain areas that they focus on. For our primary care providers, we do put more on them, but we pay them the least.
Yeah.
Out of all of our healthcare specialties. And so I know that is an issue. And yes, this upcoming generation, they do care about work-life balance, which we all should. It's what keeps us healthy. And so I think that medicine is probably going to have to change and adapt to allow for us to not only be able to continue to give good care to create healthy patients, but also make sure that we're having healthy providers. Because the way it has not necessarily done that. Again, if you have any questions, just raise your hand and we will come to you. Oh, we do have some, okay. Well, while we're going over there, just Any other ideas on any steps that policymakers can take to help improve the maternal health outcomes for Black mothers? Any ideas that you all have?
Funding postpartum care through the first year. I think that's a priority. Medi-Cal, all of those programs need to continue for the first year. There's so many states in which after 6 weeks postpartum, all of your care, all of your insurance coverage is gone. And so if you have a condition that is beyond that period of time, then you can't get care. And so we're seeing the direct effects of a lack of coverage that directly lead to maternal mortality. Like, we can see those. And so, there's states in which some of this has been passed, and that's really helpful, but that's a national priority.
I would say maybe even making sure that they build in some navigation system for our patients. Some of them don't know how to work the system and don't know what's necessary, and I think they need someone to hold their hand and make sure that they check the boxes and that things are done. So having a personal somebody, in the organizations that help them make sure, check on them. So providers can't go back and check to see, did you do X, Y, and Z, but we should have someone in our team as a navigation that helps them to make sure that they did follow up on this, that they got their ultrasound in time, that they did their blood work, or whatever that is. Check in and say, how are you eating? I mean, we just need someone to check in on these people.
I think to pull the thread through on both of those is the funding and the navigation, but collecting the right data on all of that. That slide that you had that had just all the states doing disparate things, and I think we found out during COVID that all the states and counties were doing disparate things. They were counting different metrics of data, but more standardized data collection. I have a mentor, Dr. Frida Lewis Hall, who says you can't fix what you don't measure. And so I think that is a real pressing issue, that there is some better standardization, legally and ethically. I can hear my pharma lawyer in my ear, legally and ethically, a legal and ethical collection of it, but something that there's a better sort of baseline to measure from, and not we're all kind of grabbing at apples and oranges and trying to fix a problem that's not being accurately measured.
Thank you. Our first audience question. Okay.
Hi, everyone. I'm Dr. Yendi Linares. I'm one of the, so nice to meet you finally. I'm one of the pediatricians with Children's Primary Care Medical Group. I came down here a couple of years ago after working in LA for Children's Hospital Los Angeles. And San Diego was a shock to me. It was, I'd never lived here before, and it really was a shock. So for me, now I've been, I usually am that first doctor who the mothers see afterwards, because I'm doing the postnatal care, for the newborns. So I think, it's really important that we kind of encourage that prenatal visit with the pediatrician, because a lot of families don't know that can be paid for, so that we can consult on what how you want to take care of your newborn, what your lactation plan is, just meeting that person that can reassure you. So I think, if we can encourage people to take more advantage of that prenatal visit while they're pregnant with their new pediatrician, and that way you don't have that stress of trying to pick someone randomly in the hospital and not really finding somebody who can support you. And then I was just so excited to hear about the 4th trimester project, because I really do feel that I'm the one that sees the mom 10 times, because I'm following up on the weight and the bilirubin and all of this stuff, and yet we don't follow up with the moms for until the 6-week visit. I have a 3-month-old. I just gave birth, and I didn't see my OB until 6 weeks after my C-section, which I don't. I know how to take care of myself, fortunately, because I can advocate for myself. But I don't think that should be the standard of care, and I do think that there should be more frequent postpartum visits for the mothers, and obviously encouraging everybody that's interacting with that new mother to take care of herself. So I'm always the one asking, okay, how are you doing? How are you feeling? Are you going to the doctor? Or, how are you surviving through no sleep? So I feel like funding for those expanded visits right after birth is really important. But yes, also that prenatal visit that people can take advantage of that oftentimes don't. So that was my comment, and just wondering if you guys in that 4th trimester project are going to be incorporating those more frequent visits for the mom.
Yeah, absolutely. I mean, it's our, moonshot program, because really it's not reimbursed in any way. And so we need philanthropy to help us with it. We know it's the right thing to do, but it's almost impossible to pay for it. Because there's, you don't get, whether you see somebody once or you see them 10 times postpartum, the reimbursement is the same. And we need to put people there, like we need to be able to pay for providers and all of the services that we know people need. We need to be able to pay for that. So yeah, I mean, that's going to be part of it. And, we are looking to philanthropy, working with philanthropists to help us to be able to do this for everybody. But it's a huge problem. And you're very correct. So thank you for your comments. I also had the same shock in getting my kids to see a Black pediatrician. It was impossible in San Diego, whereas in New York, it was just normal. Yeah. So it was really eye-opening for me.
Yeah. Thank you so much for those comments, and it just highlights the role. As we sit up here and we talk about the primary care provider who sees the patient for a long time prior to them getting pregnant, the OBGYN who manages them during the pregnancy. The other partner in this whole scheme is actually the pediatrician, because you do oftentimes see not only the kid but the parent, the mother who brings the child in a few days after birth, 2 weeks after birth. And so you do get the opportunity to see what's going on prior to that. And I was at some event, I think last week, and someone had brought up the idea of having pediatricians do that first kind of postpartum depression screen. And I said, well, that would be another thing on their plate. But also the question is, here in California, how can we facilitate that? Because we have some interesting laws about what you can and cannot do if someone is not your actual patient. Like I don't know how you train, but where I trained, I could do circumcisions prior to baby going home. Came to California, couldn't do that because our laws here state that once that baby is delivered, it's not my patient anymore. So I can't actually perform the circumcision. That has to be done by their provider, which is a pediatrician, which ends up happening outside once that baby is discharged from the hospital. So pulling in the pediatrician in the improvement of everything that's going on is going to be critical, and something that we will have to try to figure out how we can do from a legislative role. So thank you so much for bringing that up. We have another question.
Hello everyone, my name is Samantha Williams, family nurse practitioner, founder and executive director of Gyra Providers. So Dr. Weber, you made a really critical point earlier regarding how policy and practice can change. We know it can change from administration to administration. The thing that troubles me the most is the effort that we often put into increasingly building capacity for a lot of our larger institutions that for so long have not served us. And so those are power structures that just have not served us well. So my challenge to us in this room and beyond is to decrease the capacity that those institutions have to treat us as a commodity and continue to generate revenue when it serves them, but to instead help us to reimagine what it looks like really building community partnerships. The first one that I can think of is recently I had an experience at the San Diego Community Birth Center, owned by, I don't know if Nikki Helms is in the room. That was an experience that was it was ground shifting. I literally wept during the tour because it's an experience that as a Black woman, I only wish I could have had at 15 when I had my first child. And it's an experience that I only wish that all Black women who are birthing children can have. That experience is nothing that can be recreated at any institution that we currently have in this nation. So I have two questions. There are a number of innovative and strategic solutions that we can come up with to truly have impact and bridge the gap in equitable outcomes. Do you you or any of the panelists think that bolstering those partnerships, those community partnerships, is truly possible? And then lastly, pertaining to all of the data that was shared today and that we know currently exists, does UCSD or any of the institutions that our panelists represent, do those institutions have policy specific to Black birthing women? And if they don't, why do you think that isn't so? Thank you.
Well, I'm happy to take that. So we had a panel recently with Nikki and the folks from the Birthing Center at UCSD to start to bridge that gap between institution and community. And we think it's really important. So there were a group of us who watched a film from, I'm blanking on the name of it. It was actually from a film worker who followed me for a little bit for part of this movie. Goodness sake, Spike Lee's wife. I'm just blanking on her name. Tanya Lee. Yeah. But so we watched that movie with a bunch of medical students, and then we had a panel that included folks from our community, and then maybe a month ago had our first event where we, brought in community members to a grand rounds that was given by a national midwife, and we had all of our midwives there, and we had doulas, and it was really fantastic because we really are working on bridging that gap. It's not us and them, it's us, and we're all taking care of us. I think, so those things are absolutely happening. We are encouraging our residents a lot of our residents are now going to take tours of that birthing center just to see, some of the other things that are happening in the communities. And, it's a active and conscious dialogue that we're having. And I think we're definitely making strides, particularly as we are oftentimes on the receiving end of having some of the patients from the birthing center come to us. And so it's a really important piece that we are actively participating with our community.
I want to thank you so much for that question and highlighting it because, for those who have been in the San Diego area for a while, we are aware of the historical lack of relationships with certain communities from our major institutions. And that's why, I pointed out a lot has changed in this short amount of time because it was different, right? And I think those who've been here know that. From a statewide level, these are things that we definitely recognize that we do need to start looking at and funding and supporting our community, different community organizations. We talk a lot more about doulas and funding them through insurance because we understand that you need to be where the people are, right? And so we are having those discussions and funding things differently. And I just also recommend for all of the institutions, we have historical things that have happened in history which make people a little less trustworthy. Right, and I think we saw some of those challenges during COVID when you dealt with vaccines and trying to get them to different communities, that when communities see you coming and they're like, we haven't seen you before, you way up there in La Jolla, not down here, then it impacts the ability to just provide good health care overall. And so I do strongly recommend that it should not be just you come to us, but also we are coming to you as well. And so, I'm very excited about the fourth trimester project that UCSD has. And as I was looking at it, I was thinking, and I know it's going to be money, but I was thinking, it would be so amazing if you didn't just have it in one location. If you were able to branch out and have it in other locations so that your patients that live here in this community don't necessarily have to bear the burden of trying to get all the way up to La Jolla, especially in a time frame where they've got a baby and there's stress, and the last thing you want to deal with is dealing with traffic getting up there, traffic coming back from their buses, trolleys, whatever, right? So understanding that the relationships are two-way. Yes, we'll invite you up, but we're also going to come down to you, and we're going to bring ourselves and our resources to the people so that we have a much, much better kind of relationship that has been present in the past, and that will help create healthy alliances and healthy communities. We have another question.
Feels called aftershock.
Aftershock.
Can I slide in just really quickly?
Oh, yes.
Just to follow on to something you said, because when we started doing a lot of really digging into our equity work at Pharma, we hosted a lot of focus groups for the community to say, what is it that you want to see us do? How do you want us to show up? And I'll never forget one of the participants said, well, are you coming to help or are you coming to harm? And so that has been something that's really guided me. But also we said, you know, we need to be led by the community. So our way of doing this is that we've done these grants, we call them CARES grants, collaborative actions to reach equity. And what we do is center them around a research question. So our first grants were around COVID vaccine uptake. What can we do to better educate communities of color, to encourage uptake, so we could get back to some semblance of normal like we have right now. We did some grants on social determinants of health. We just released an RFP on solutions to close disparities in cancer outcomes in communities of color. But what we've said every time is, community, you guys know best. Academia, you know best. Please bring us your solutions, and we will vet them and see which ones are, the ones that we think, to your point, are scalable and replicable later on. But we found a lot of success in doing that, and not saying we're coming with a solution, but saying we want to partner with you on solutions. We don't want to tell you what to do because you guys live this every day, but help us help you so that we can, harness our resources as a trade association, but harness our resources as an industry, because each one of our member companies is doing something on health equity. I'm sitting here thinking about Merck. They have Merck for Mothers. They do a lot of work on hemorrhage, the hemorrhage issue, postpartum hemorrhage issue, and so many other of our member companies who are doing just very spectacular work in trying to bridge some of these gaps. But it's all about like the community, what the community wants, and not us saying we've got the solution from on high, because we are contending with all of those thoughts about all the historical issues that have happened, issues of wrongs and issues with mistrust that aren't just rooted in history, but are rooted in everyday lived experiences as well.
Thank you. Good afternoon. I'm Jamie Felice. I'm a senior public health nurse, and I'm the perinatal services coordinator here in the county. Thank you for this opportunity today. And I did a biology class with Nikki Helms in 2005, so she's actually a colleague and a friend of mine. I'm also a midwifery supporter. I'm a native San Diegan. My kids were born in San Diego at home with midwives. And I appreciate the slide that you showed, Dr. Jamfi Bannerman. Thank you so much. I wonder if in your research, if you have looked at the medicalization in America and how it has contributed, and I'm grateful for OBGYNs, I have no disrespect at all. We need to work together. But I wonder if you've looked at that in your research, and many of those countries that you had listed there who had, who were less than 10, whereas, the US was 26.2 or whatever it was. If you saw that midwives are the primary providers for the bulk of the births that occur in those countries, and here in the U.S., I think about 1% of women are delivered by midwives, whereas I know that we have many, many, many low-risk healthy women who would benefit either at the birth center or at home or in hospital with the midwife as the primary provider. Not as the doula. I've also been a doula in my background. Every woman deserves a doula. I'm talking as the primary provider, and then the OBGYN comes in for those high-risk women that we absolutely need them for. We know that midwives are high-touch, low intervention. They meet the women where they're at. I know that not all docs have that time to provide that midwives do show. But I just wondered if you could speak to that. And then my second point, I'm also a public health nurse here in the county, and we do have maternal infant home visitation programs, and I think that we should talk about the 4th trimester. And I'm also a lactation consultant, and thank you to the pediatrician who brought up lactation checks and maternal mental checks at the well baby checkups. Thank you so much.
Thanks for the question. I think you are exactly correct. Some of the models in Europe are just very different from its inception, and have majority midwifery care for pregnant people, and then the OBGYN only sees the higher risk or someone needs a C-section. The system, and Dr. Weber said this the best, I mean, there's so much history in this country about the way that things have come through, and so the systems are just a little bit different here. And even if we, at this point, said, let's just replace it, we don't have enough midwives to replace, we're not at a place yet where we can just switch. Having said that, I think having a midwife involved in the training of an OBGYN is incredibly important. And I was fortunate to have that when at the University of Miami. And we have an incredible team of midwives who train our residents at UCSD. We have a separate midwifery service. I completely agree with you, a midwife is not a doula. Doulas are fantastic, but midwives deliver babies. And we have the ability to have our residents see our birthing center. It's all one continuous labor and delivery. So it's the birthing center, it's the midwives, they cover us sometimes if we're doing something and we can't deliver a baby, we cover them. We're colleagues. There's no issue there, and that's the way it should be everywhere. I mean, I think that's some women seek midwifery care, some women are co-managed by midwife, and me as a perinatologist. Everything goes, and so I agree with you, and it would be great to have more people have the ability to get midwifery care. I think what we're seeing, not only here in San Diego, but in the country, is that women are they're getting a little bit older, they're getting a little bit sicker, they're getting a little bit heavier, and having their first pregnancy at that time. And so I think the ability for us to work together is really going to be the most important thing. There's some very academic midwives that I've worked with too to kind of write guidelines, and just some of the best people. And so I wish we can work more towards that relationship. So I really appreciate your question.
Yeah, and I would just, echo what my colleague says. I think a couple of things. One, most OBGYNs are trained in a setting with midwives. Even at Cook County, we had an amazing midwifery service. They were really good, and very, very lucky to train under them. Two, I think there's also a need for more midwives, but I also think that there's also just a need for more education around who midwives are and what they can offer. Because we live, unlike some of those other countries where when you're pregnant and you get a provider, your provider is a midwife, right? Here in the United States, people are given a choice. Do you want a doctor or do you want a midwife? And so oftentimes they will choose the MD route, where in other countries they are given a midwife until something happens and they have to get an MD instead.
I would just challenge you that in California or in San Diego, that's not the case. So our Medi-Cal is really where the issue lies, that there are not enough midwife providers. It's very difficult to become a Medi-Cal midwife provider. You get to choose family health, you get to choose Grossmont, Sharp Grossmont, or Scripps Mercy to deliver. You don't get to choose a midwife. So I'm sorry, I didn't mean to throw that out, but I believe that there is, unless you go to the Start Birth Center, or if you hire a home birth midwife who happens to be a Medi-Cal provider. So I think that it is in the system. I think it's in the system, it's in what's available for families, and that is very, very medicalized. It's just hospital birth is the norm.
Yeah.
And that's just what you get. You get the doctor in the box, you get whoever you get, and that's that. So.
Well, I can speak to my experience. When I was at UCSD, when patients came for their intake, they were asked, and I'm assuming that's still the case, right?
That's UCSD.
You ask, do you want it to be delivered by a midwife or do you want to be delivered by a physician? And if they said we want a midwife, in fact, they could transfer up to 36 weeks to the midwifery service. So Yeah. Okay. I have been told that this is our last question, and to be honest, y'all, I was supposed to stop questions a long time ago. But this has been such a very good discussion that I was like, we're just gonna keep going till 2 o'clock. So this will be our last question.
Hi, good afternoon. I'm Lisa Kilgore. I'm the Director of Epidemiology and Quality from Scripps Health. I have actually a statement and a question. The question you may not have to answer, just something to think about. First statement is my daughter and her husband and grandchildren, my grandchildren, are in Chicago/Indiana. The healthcare is subpar. I have gotten on the phone with her I don't know how many times to actually speak with the risk manager at the hospital where she's delivered her last child, who was 3 years old, but her problem is abdominal pain, and she is in and out of the urgent care and ED probably at least once or twice a month, just as recently as yesterday, and was sent home and said that it's probably a hernia, and if she chooses to have another child, then they can't repair the hernia. I'm not sure how accurate all of that is. And then my question, which is something to just think about, is there are preventative measures that you're all talking about, which I think are outstanding. I am definitely not of childbearing years. I have 6 grandchildren, so that is not a thought in my head. However, have you all ever thought about partnering with anyone from infection prevention or epidemiology in order to prevent these diseases such as primary and secondary syphilis, gonorrhea, VD, and all of these other preventative measures in order to prevent the scar tissue that develops on these women of color when they're not so smart when they're younger? And so that's just something to think about. That question does not need to be answered.
I think that is, prevention is always the key, right? And I am a huge proponent of preventative medicine. That's why I'm a huge proponent, and I talk about this all the time, social determinants of health. Because, we can do everything once someone comes to you as an adult to get them ready for pregnancy, and then once they're pregnant, they can have the best care. But the reality is, because of social determinants of health and weathering, their bodies are already at a different state because of chronic stress. And so fixing this is a broader problem than really just looking at the medical system or the pharmaceutical industry. It's really looking at society as a whole. Where do you live? What are you exposed to? What kind of systemic racism are you encountered from day one? And how do we improve academic outcomes and put everyone kind of at a different level? When you, Dr. Afalo, were talking about patients needing to advocate for themselves, during their pregnancies, I completely agree with that. But you shouldn't necessarily have to, and it shouldn't necessarily be on the burden of the woman. And we need to get to a place in society where that is no longer needed. Because when you go in already knowing, okay, I got to be an advocate because this person isn't going to listen to me, you're already tense. Your body's already stressed, right? And so it puts us at a disadvantage that we shouldn't have to be at. And so there's so much to it that we need to fix. And I really just want to please give another round of applause to our esteemed panelists for this. I want to thank everyone here for joining us this afternoon. I want to thank our partners in putting this together. I hope you all have learned some very insightful things and feel energized to continue raising awareness around Black maternal morbidity coupled with chronic disease. And please remember that when we talk about improving these things, when we talk about racial and economic inequalities, that just doesn't lead to worsening outcomes for those particular individuals. It leads to worsening outcomes for all of us. And that's why we see the United States at such a much lower rate when we're talking about maternal morbidity and mortality overall when compared to other developed countries. That's why we see the United States at lower life expectancy overall when we're comparing it to other developing or developed countries. And it's because we have these issues that we have not addressed. So it's not just something that ultimately impacts Black women or Native American women or Latinas. It's something that ultimately impacts the entire health of this entire country. So thank you all very much for your time and your interest and all of your questions. Thank you.